Hello, I'm Boris Bibov, an epidemiologist and data scientist, and also the author and maintainer of the kidney.epi package. I would like to thank the organizers of the conference for providing me an opportunity to highlight how the package could facilitate research in diabetes, heart, and other diseases. First, let's talk why kidney diseases are important. And the number of people living in the world with chronic kidney disease increased almost twofold over the past 30 years, and it reached 700 million persons. That means that almost 10% of the world population have chronic kidney disease. Chronic kidney disease are more prevalent than cardiovascular disease, neoplasm, diabetes mellitus, and chronic respiratory disease. Moreover, age standardized rates for chronic kidney disease over the past 30 years increased, while for many non-communicable disease, these rates decreased. And that means that in the future, we expect to see more patients with chronic kidney disease. Some high-risk groups, and you can see that diabetes, hypertension, and rheumatoid arthritis patients have much higher prevalence of chronic kidney disease, reaching 20, 30, and even 60%. Moreover, almost 40% of all population aged 65 years and older have chronic kidney disease. And it's extremely important because kidneys are the major route of elimination of many drugs from the body. And decreasing kidney function requires either reduction or even became a contraindication for administration of the drugs. And you can see here only a small portion of the table related to the anti-diabetic medicines. Paradoxically, despite this high role and high prevalence of chronic kidney disease, patients with CKD are frequently excluded from the randomized clinical trials. And here you can see the results of analysis of how many patients, how many randomized trials on cardiovascular disease medication excludes chronic kidney disease. So almost 80% of all trials exclude CKD patients, and almost 40% of all trials exclude even early stages of CKD that is extremely prevalent in the general population. Hopefully, the situation improves. And just several weeks ago, the World Health Organization has adopted the kidney health resolution that is aimed to promote kidney health and improve prevention and control strategies for kidney disease. So let's see how kidney APR package could help in this field. The package provides a set of functions for clinical and epidemiological research, and all functions are programmed to be flexible. You don't need to record your data. Instead, functions adapt to the data, and the detailed documentation is available on this link. So the package contains synthetic dataset for testing different equations, a set of functions for calculating estimated glomerular filtration rate with functions having eGFR prefix, functions to recording data to the modern KDIGO disease classification that have CKD prefix, and functions for calculating risk score specific for kidney transplantation that has KTX prefix. The modern KDIGO classification is shown on this slide, and it's actually based on two major markers, glomerular filtration rate and albuminuria. Let's start with the glomerular filtration rate. What is this? It's a volume of blood plasma filtered in kidneys per minute, and it is expressed in milliliters per minute, standardized to body surface area. Glomerular filtration rate indicates how well the kidneys are filtering blood. It is used for dosing adjustment of many medicines, and the level below 60 indicates a clinically relevant decrease in kidney disease. Kidney.epi package has naming pattern for the eGFR equations that include equation name, biochemical marker, and equation version if it's available. For example, here you can see the most widely used CKD-AP 2021 creatinine-based equation, and here the calculations inside this equation itself. So the naming is eGFR dot kidney.epi as the name of the equation, creatinine CR because it used this biochemical marker, and the version. Apart from creatinine, some equations use also cystatine C, or use both creatinine and cystatine C levels in the blood, and this is indicated in the names of the function. The serum creatinine can be measured in milligram per deciliter, millimole per liter, or micromole per liter, and you do not need to record your data to any standard definition. You just need to define as a function parameter creatinine units, the units that used in your data set. In the same way, many functions use not only a biochemical parameter, but also other variables like age and sex. And you do not need to decode labels used in your data. And for example, for sex, you can use the function parameter label sex male and label sex female, and define in this parameter which labels are used in your data set. And these labels could be any, depending on your data set, whether you use numerical labels like 0 or 1, string labels, or SNOMED or WOINC codes, or any other codes from other ontologies. So you can just define them in the function arguments and use it. Other functions for calculating eGFR include also ethnicity, and ethnicity labels also could be used as a function parameters. Here you can see an example of application of the kidney.epi function to a single patient. You set the creatinine, age, sex, creatinine units used, and the labels. And as an output, you have the numeric values of the estimated glomerular filtration rate. When you apply the kidney.epi functions to your dataset, you should define in each argument the column from your data, and also the creatinine units and labels for sex and females that are used in your data, and then the function perform automatic data check. For example, here you can see that there were more than 800 values that have age lower than 80, and because kidney.epi equation was developed only for adults, these patients will be excluded from the analysis, from the calculations. And after the automatic check, you can use the received numerical values for the further analysis. Currently, you can see on the slide all eGFR equations that are implemented in the kidney.epi R package, and they are quite numeric. And here some simple visualizations where you can compare the different equations. For example, the kidney.epi 2021 equation, because it was developed only for adults, the values for the children are not calculated, while in the full age spectrum equation, values both for the children and adults are calculated, and you can use them further in your analysis. Kidney.epi package also contains functions eGFR.alladults .creatinine, cystatine, or creatinine and cystatine for batched application of all equations for the same patient cohort. And here you can see the data frame resulted in application of these functions, and you can compare the numeric values of estimated glomerular filtration rate that are produced by different equations. Knowing estimated glomerular filtration rate, you can map these values to the categories of the KDIGO classification: G1, G2, G3A, G3B, G4, and G5, using the function from the package ckd.kdigo category G5. Here is an example of the usage, and as an output, you will have the names of the categories. Now let's look to the second major marker of kidney disease. It's an albuminuria that is used in the KDIGO classification also. Albuminuria is an amount of albumin in urine. It indicates the integrity of filtering membrane in kidney structural units, and because healthy kidney stop most of albumin from getting through their filters and entering urine, the increase in urine albumin suggests kidney disease. And albuminuria itself is an important early marker of kidney disease in diabetes, hypertension, and other high-risk groups. Albuminuria can be expressed in case of 24-hour urine collection as milligram per day, and in case of measurement as a ratio between urine albumin and urine creatinine, either as milligram per millimole or milligram per gram. Albuminuria can be measured quantitatively, so as an input you will have numeric values. Semi-quantitatively, as an input you will have categories of albuminuria, and qualitatively, so as an input you can have 1, 2, 3 pluses. But even in quantitative measurement, the albuminuria values could contain some string variables because laboratory kits have lower detection limits threshold, and levels of albuminuria lower than this threshold are just coded as less than, for example, 17. So, and the kidney-API functions can manage the presence of these characteristic values in a numeric column. So there are two functions for classifying the values of either albuminuria or proteinuria to the grades of KDIGO albuminuria, A1, A2, and A3. There is a particular aspect of this categorization because the limits of these categories is defined differently a little bit. It's a small difference, but it's still, as you can understand, important from the perspective of data analysis. And in some cases, these limits are defined as up to 300, in some cases up to 299. So the kidney API R package functions, CKD albuminuria category, uses the following thresholds for quantitative and semi-quantitative data analysis. And how to interpret the string values and semi-quantitative values in the data depends on the argument semi-quantitative values that is a part of the kidney API functions. So if the semi-quantitative values equal any, the function will code any values, whether it will be lower than threshold quantitative values or semi-quantitative values. In case if semi-quantitative values argument is only limits, the function will exclude the values of semi-quantitative analysis. As you can see, they are substituted with NA here, but will classify the string values referring to lower than laboratory equipment threshold parameter. And if the argument semi-quantitative values is equal to forbidden, only numeric values of albuminuria will be classified as classes of KDIGO classification. Having information about both albuminuria and eGFR grades, KDIGO classification allows to determine the risk of complications, cardiovascular or end-stage kidney disease event, as you can see here on the color mapping. So the basal risk refers to the absence of chronic kidney disease. It's a green. Moderate risk depicted here is a yellow, and high risk orange, and very high risk as red. So kidney.epi R package has a CKD KDIGO category risk function that allows you to use and argument the labels of KDIGO albuminuria and KDIGO eGFR categories, and have an output of KDIGO risk categories as a very high, high, moderate, or basal. Kidney AP functions also allow you to produce a matrix of values of eGFR and albuminuria categories in your data, and save this matrix to Excel file for further usage in publications or in data analysis. There is a possibility to use the results of kidney APR functions in advanced visualizations that are not included in kidney AP function. And the scientific tool sorts provide a limited number of free waivers for researchers from low and middle income countries. And here you can see the example of this advanced visualization with provision of very complex, very rich data in a clear and concise way. And from this visualization, you can easily catch that, for example, in high-risk urban population, the number of the percentage of people with the A3 category of albuminuria is much higher than in rural area population. And in rural area population, the percentage of people with advanced eGFR stages is much higher than in the urban area. And moreover, even the percentage of total CKD prevalence is quite similar in rural and urban populations. From this advanced visualization, you can easily catch that the very high risk of complication is much more prevalent in rural population compared to urban. So this advanced visualization can facilitate the perception of the complex information and also facilitate the decision-making process. Kidney APR functions also contain some functions specific for kidney transplantation, and in particular for calculation of kidney donor risk index and kidney donor profile index. Detailed explanations are available here on this address, and I would like just to mention that this kidney transplantation function follows the same pattern. You can define the arguments, the data itself, the labels used in your data, according to which the functions will classify internally categorical values, and you can define the return output and which mapping year to use in the calculations. So let me conclude that the kidney API CRAN R package facilitates research in many areas, not only limited to kidney disease itself, but it concerns also diabetology, cardiology, rheumatology, gerontology, and so on. Knowing eGFR is extremely important to monitor appropriateness of medicine's prescription. All functions included in the package are flexible. They adapt to the data, and you do not need to modify the original dataset. More will be implemented in the next packages. You can support the development of the package, and you can contact me in case of any questions or inquiries. Thank you so much for your attention.
Congratulations. This is a fantastic package. You've gotten a lot of compliments in chat. I think there's a number of people who are very impressed by the flexibility and the quality of the package, the documentation, the code, and how user-friendly your package is. So we have a few minutes for questions. So Ben has a great ask here. Ben Gerber asks, could you please speak a little bit more about scientifictools.org, who I believe is the sponsor of this package?
It's not a sponsor, it's a research consultancy agency. And if you need any inquiries, I will be happy to consider new projects to follow and to participate in. You can find more information at the website.
Excellent. There's another question in chat. Do you have any advice for working in healthcare data that early career professionals in biostatistics without a medical background might miss?
I think when you work with medical data, you need to communicate closely with physicians or with medical staff. And it's very important to listen, to reflect, and then to be sure that you correctly understand what do medics told, and communicate with them one more time just to have the feedback about your understanding.
Excellent. All right. Any other questions? All right. Well, thank you so much. This is a great package. I can't wait to dive in and learn more about it. Thank you so much for making this really valuable contribution to the community. And thank you for participating in Our Medicine 2025.
Thank you.